Hello, my name is Anwar, and I am on faculty at the Emory University School of Medicine. My primary clinical site is at Grady Memorial Hospital, and I am excited to bring to you our SAEM didactic about how to propel your curriculum using ED observation. This global pandemic has taught us a number of things. Number one, professionalism is an issue from the waist up. Like, you guys don't even know if I'm wearing pants. But number two, it's taught us that observation medicine is an exciting field and flexible and can be molded to the needs of the hospital. And so residents need to learn this. To that point, we have brought together some of the best lecturers and observation leaders in the country to deliver succinct lectures on how to really make your curriculum cutting edge, fantastic, and something that residents are going to benefit from. So please sit back and pay attention, take notes. I guess you can rewind now that it's all on video. But feel free to email myself or any of my colleagues / friends in this video about any questions that you might have about how to get your ED OBS curriculum off the ground. Thanks.
Hello, everyone. My name is Margarita Pena, and I practice emergency medicine and observation medicine at Ascension St. John Hospital in Detroit, Michigan. Thank you for the opportunity to present our didactic session, Propel Your Curriculum with ED Observation, integrating an evidence-based model of observation care into your resident education. We're going to start off this didactic session by talking about observation care and observation medicine clinical skills. So what is observation care? CMS defines observation care as a well-defined set of specific clinically appropriate services provided to a patient while a decision can be made as to whether they can be safely discharged or if they require further inpatient treatment and management. Observation care can be provided in 4 types of settings. Most patients in observation status in the United States are cared for in a type 3 or 4 setting in an inpatient unit, where they may share a room and be indistinguishable from a patient who is a full admission. In other words, all orders are ordered as routine, there is no difference in frequency of rounding, etc. In a type 1 or 2 setting, patients requiring a short stay, typically less than 24 hours beyond their emergency department stay, are cohorted into a distinct observation or short stay unit. Who is best suited to manage and staff a type 1 protocol-driven observation unit where the average length of stay is about 15 hours? Well, we would want physicians to be disposition-driven, time-conscious, be able to rapidly evaluate, prioritize, and multitask. Well, I know who that is. That's an emergency physician. This skill set is what our residents learn to do from day 1 of residency, and it's a skill set unique to emergency medicine. The number of hospitals opening observation units has significantly increased over the last almost 20 years as evidence continues to show that observation units, and specifically type 1 observation units, are more efficient, safer, and cost-effective when compared with care in an inpatient unit. In fact, the most current National Hospital Ambulatory Medical Care Survey data shows that almost half of hospitals have an observation unit. Therefore, your residents will likely be employed at a hospital with an observation unit, and it's important that they learn about observation medicine. Observation medicine encompasses the skill and knowledge needed to identify and actively manage observation-appropriate patients. There are specific clinical skills learned by studying the science of observation medicine and working in a type 1 observation unit, and it's important to note that these clinical skills will improve and augment your residents' emergency medicine clinical skills. In fact, the 2016 Emergency Medicine Clinical Practice Model includes observation and reassessment as one of the key emergency medicine physician tasks. As Hippocrates, the father of medicine, is noted to have said, a great part, I believe, of the art is to be able to observe. And we know that disease severity changes with time. Therefore, the more time a resident can observe a patient through their disease course, the better that resident becomes at following the course of that disease, and in this way, they become better predictors of patient outcomes. Historically, emergency medicine residents were exposed to non-ICU disease pathology beyond the acute ED phase by by rotating on inpatient medicine wards. However, there's been a trend among emergency medicine programs recently to eliminate inpatient ward experience. In fact, in 1986, 74% of emergency medicine residencies had internal medicine rotations. However, in 2018, only 23% of three-year residency programs included an internal medicine rotation. There is now another disposition option to observe patients beyond their acute ED presentation. And as the majority of observation units are emergency department managed, residents now have an opportunity to observe disease progression beyond the typical 4 to 6 hour ED stay to about 24 hours in an observation unit. So what are some specific clinical skills learned by studying observation medicine and working in a Type 1 observation unit? The EM milestone Patient Care 7 states that residents should be able to correctly assign admitted patients to an appropriate level of care. In other words, ICU versus telemetry versus floor versus observation unit to reach a level 3. By seeing how certain diseases progress over time, a resident's ability to predict a patient's disease course will improve. Furthermore, learning about observation medicine and or working in an observation unit, residents will learn to make better disposition decisions about which patients and conditions are most appropriate, not for just admission versus discharge, but also which patients are appropriate for a short stay period of observation. As Type 1 observation units utilize evidence-based clinical guidelines and protocols that are feasible within 24 hours, residents will also learn how to treat observation unit conditions such as chest pain and asthma and make timely and appropriate diagnostic and management decisions such that a safe and appropriate disposition can be made within these 24 hours. Evidence demonstrates that observation unit appropriate patients are those that are non-high risk. In other words, they are of low to intermediate risk. Therefore, the resident will improve their risk stratification skills beyond sick versus non-sick by learning more about criteria which make a patient low risk versus intermediate risk versus high risk for certain conditions such as chest pain, heart failure, and syncope. In an observation unit, residents will also work closely with consultants, non-ED ancillary services such as PT, OT, and case management and social work to coordinate care and ensure safe and effective discharge planning. Therefore, the observation unit experience will enhance their team management skills. And finally, in learning about patient care using protocolized pathways, residents will also learn about practicing cost-appropriate care and resource utilization. Furthermore, the observation medicine curriculum that Dr. Wheatley will cover next also includes knowledge of observation unit documentation and billing. So in summary, your resident will likely work in a hospital with an observation unit after graduation, so it's important that they learn about the science and practice of observation medicine. In addition, clinical skills learned through the study and practice of observation medicine will improve and augment their emergency medicine skills. And therefore, observation medicine should be included in emergency medicine training. Thank you so much for your time and listening to this didactic.
Hello, my name is Matt Wheatley. I'm one of the faculty at Grady and Emory. This section, we're going to talk about designing and implementing an observation medicine curriculum at your emergency medicine residency training site. A little bit about me. This is my picture from when I wore a suit and had a beard before all this craziness started. As I mentioned, I work at Emory and Grady. I'm the associate medical director for the ED at Grady and work mainly with the observation unit, which I've been doing since 2009. Also the outgoing chair for the ASAP observation medicine section. The three main things I want to talk about today for curriculum design. Number one, the why of it. Why would you take a perfectly good emergency medicine training program and try to work in another rotation or another curriculum? Once you answer that question, once you convince yourself that this is a good idea, then some of the other dominoes start to fall into place, specifically the what. and then the how and who should run this and who should do it. As we look into why, think about the first patient you rounded on in the observation unit. For me, this was done as an attending, and it was confusing for me because I had admitted plenty of patients to the observation unit as a resident. I just never rounded on them on the back end. I'd never seen what it was like to assess a patient who is complete with a protocol or in the middle of a protocol and decide, do they need to be admitted or do they need to be discharged? And I remember coming onto that first shift where I was supposed to round in the obs unit before going into the ED, and going and grabbing one of my colleagues who was working and saying, what do I do here? How do I write the note? How do I do the discharge instructions? What do I need to do to assess them? What we're finding is that a lot of our grads at Emory are going to sites where they are responsible for rounding in obs units, or they're even being asked to run an observation unit. They're being tapped by their medical directors and saying, hey, we're going to start an obs unit. We're going to expand this obs unit. We want you to be the medical director. So I think for those reasons, working observation medicine into emergency medicine training is important. It's as important as teaching the trainees ultrasound, teaching them concepts of EMS, toxicology, those kind of things. It's equal to other subspecialties within the House of Emergency Medicine, and it should be taught similar to those. We have published a model longitudinal curriculum in academic emergency medicine. So please look at this paper here kind of for a deeper dive and more specifics in terms of, reading lists and didactics and stuff like that. But we're going to talk about some of these concepts more on the surface, just given that this is more of a short talk here. One of the concepts that is important, I think, for observation medicine is that the learning be longitudinal throughout residency training, and that the concepts of observation medicine that we try to impart upon the learners are in accordance with their level of training. So, for somebody who's an intern or PGY1 level, they really just need more basic familiarity with the concept of an observation unit, the fact that it exists, it's a disposition option for your patients in the ED, and they need to become familiar with fine-tuning their patient selection. As the PGY 1 year kind of wears on, starting to include concepts of maybe some of the more simple bread and butter protocols are good in terms of, protocol design and inclusion, exclusion, disposition, those kind of things. As they transition into PGY 2 year, this is a good year to really start to get them familiar with following patients through the observation unit. This may be a good year to start working in some shifts in the observation unit where they're actually responsible for dispositioning patients and writing notes and stuff like that. As they move into senior year, either as a PGY 3 or PGY 4, depending on how your residency is structured, then they can look more at the unit itself and look at things like quality metrics, occupancy, length of stay, and work on various QI projects as a way to kind of improve the unit and better understand this. And then as, for PGY 4s or, possibly fellowship level, talk about concepts of starting or expanding a unit. So this kind of thing, and these aren't obviously hard and fast rules, but it's just a way to transition them from, very easy kind of patient level stuff to more unit and ED level stuff. As we're looking at the what of the curriculum, we obviously don't want to focus just on, PowerPoints or lectures, but you want to make sure that it's a well-rounded curriculum that gives the learners the ability to do some self-directed learning, and obviously you want to weigh heavily on the clinical rotation, the clinical experience of this. Didactics obviously do have their place And, certain things, certain concepts I think will work best kind of in lecture format, but also depending on how the rotation is set up. If it's a dedicated rotation with a small group of learners, so maybe some small group discussion or case-based learning are better for those things as opposed to just a PowerPoint lecture. One of the challenges for any residency program is going to be to identify kind of who your OBS faculty are. So this could be your observation unit director. It can also be other folks who've trained in residencies where you had OBS units, or people who have familiarity, or this is kind of a level content expertise. Some of it may be based on what strategy you're going to have. If there is going to be more of an OBS medicine block in your residency educational curriculum, you'll definitely need OBS faculty who can, do these lectures or run the small groups. If you decide that it's better to maybe pepper OBS-specific topics throughout the curriculum, then you can probably rely on just your kind of general faculty to bring those concepts to bear. An example of that would be introducing concepts of low risk chest pain and stress testing in your cardiac module, or introducing concepts of TIA and small stroke workup, in your neurology section, where you would have a bigger talk or lecture on low risk chest pain and then talk about use of the OBS unit within that, as opposed to a dedicated OBS unit lecture. Here's a list of some sample didactics. This obviously is not exhaustive. There's more that are listed in the appendix of the AEM article, which I mentioned earlier on. The dedicated OBS rotation will be focused on by one of my other colleagues, but these are some questions that it's important to answer, I think, as you're trying to wrap your head around, starting an OBS unit rotation. Which year of training will we start working clinical shifts in? Will these be dedicated observation shifts, or will they be hybrid observation ED shifts where the resident will rotate in the OBS unit and then go out to the ED and work in the ED? Will this just be for a dedicated month in a certain clinical year, or will this be spread throughout the throughout their training? It's important not just to, again, have lectures and the clinical experience, but also to have some ability for learners to do some of this stuff on their own. So some of that is, foundational readings and at least reference stuff. I've included a link here for the appendix for the AEM article. Again, these readings could be assigned readings, or they could be jumping off points for other small group discussions or case-based learning. Depending on the level of interest and the motivation of your learners, getting them involved in a QI project for the observation unit, I've found is a good way to kind of engage and deepen some of the concepts of observation medicine. Definitely if you have residents that are interested in maybe admin fellowship or even observation fellowship, this is a great way to get them involved. Getting them involved in other kind of research projects is also a good idea. Patient logs, this is a good thing for early learners, PGY1s, they have to do patient follow-ups anyway for as an ACGME requirement. So, having them focus maybe on some of the patients they send to the OBS unit is a good way to kind of reinforce concepts of patient selection and outcomes. Last thing to discuss here is evaluation, both of the learners themselves and also of the curriculum. It's important that you as observation curriculum designer get some feedback from your learners as to how they're liking it, and that way you can make changes as needed. You can do this through your course evaluation. You can also do it through exit interviews with your learners. Evaluations of your residents can be done using the appropriate EM milestones. I've shown the one for observation here. That's probably the most specific for observation, but if they're doing a dedicated rotation, things like medical knowledge, patient care, systems-based learning, all that stuff would apply. And then doing some one-on-one post-shift feedback, especially if you have a smaller group of learners, is a great way to provide them some evaluation. So that's really all I have in this short little talk here. I wanted to leave you with these resources here in terms of papers that have been published on this topic that dive into this a lot more deeply than I was able to go into now. Also, the ASAP OBS section and the SAEM Observation Interest Group are two great places to get involved with other folks that are doing the same thing. Both of them have email groups that are very active in terms of asking questions of how to develop this and get other ideas from other folks. So I will leave it there. I thank you for your attention. If you have any questions, this is the best way to contact me here. Thanks so much.
Depending upon the size, location, staffing model, and structure of your observation unit, there are various ways in which residents can be exposed to observation medicine. Over the next few slides, I will discuss how to design a dedicated observation medicine rotation based on the model we use at Virginia Commonwealth University Health System Emergency Medicine Residency Program. Ours is a traditional 3-year residency program, and we require second-year residents to do a 2-week rotation with us in the clinical decision unit. They're excused for a half day every Wednesday AM to attend conference. Residents do a total of 10 shifts Monday through Friday with weekends off. We have 16 beds with a high turnover rate, so it's a fairly busy rotation. It may not be possible or practical to have all the prerequisites listed on this slide, but even if you have 2 or 3 of them in place, you should seriously consider an observation medicine rotation. A dedicated unit director can serve both as a catalyst as well as a role model for residents. Every emergency department has a few physicians who enjoy teaching but find the task challenging in the busy environment of the emergency department. These educators can be persuaded to work in the CDU or the observation unit during resident rotation blocks, which is a great setting for one-on-one teaching. I have been able to get most of my EM ultrasound faculty to do shifts in the CDU, and they love to be able to incorporate observation medicine teaching with bedside ultrasound. In the era of tight budgets, it is very difficult to get any release time to teach. But if you are able to convince your institution and your department to support the faculty for even a few hours a week of dedicated teaching, your OM rotation will become a favorite among the residents. By the nature of the beast, a closed unit where only a well-defined set of providers is allowed to work is the best type of setting for teaching to occur, since it lends consistency and control. Observation medicine has elements of both emergency medicine and inpatient medicine, and so, if you happen to have some dual trained faculty, please encourage them to get involved in observation unit teaching. And lastly, if your unit is running well, by which I mean that you are meeting the targets of length of stay and patient outcomes, then just having a resident rotate there will provide a great experience. Here is an example of how we have designed the observation medicine rotation at VCU. All ED physicians, including me, have some degree of ADD in us, which is one reason why we gravitated towards emergency medicine. Therefore, we structured this rotation to mimic the multitask workflow of the emergency department using a hybrid strategy of inpatient style rounding and priority-based ED approach. A typical shift starts with the attending, the rotating resident, and the APP getting a formal sign-out from the night team, which takes an average of 20 to 30 minutes. Rounds are very fluid and disposition-driven. We use portable workstations that enable us to make phone calls, place orders, request consults, and put in discharges simultaneously. While rounding, if we get admission requests from the emergency department, we break rounds and send someone from the team to see the new referrals rather than wait to finish rounds before seeing new patients. Our self imposed response time to ED referrals is a maximum of 15 minutes. As opposed to the madness of the emergency department, an observation medicine rotation in a dedicated unit affords time to do high impact bedside teaching, including physical exam skills. Based on numerous studies showing that patients love it when you discuss their case and treatment plan in front of them, we have adopted this approach and continue to receive positive feedback from patients about it. We often hear our patients say, "No one ever explained it to me like that." 2 to 3 times during the rotation, the attending takes the resident on field trips to cardiac testing area, hemodialysis and endoscopy suite to show them how these areas operate, introduce them to staff who can interpret results in real time, and learn from what our patients actually go through when they get these studies and what to look out for. Residents find this very useful as they build relationships that can be leveraged when they go back to the emergency department. Beside teaching on rounds, we have formal didactic teaching that involves short reading assignments from our teaching file with questions in the form of an informal daily quiz at the end of shift. Many of our graduates were calling us wanting help with the business plan for starting an observation unit. So we also include a few formal presentations that address the nuts and bolts of observation unit setup, staffing, and financial viability. And when you get all fired up about going home and starting an observation medicine rotation, I have to caution you about some pitfalls. If your rotation is a hit with residents, you may get requests from medical students, APPs, or internal medicine residents looking for learning opportunities. You will have to be careful how many learners you can take on depending on the size of the unit and staffing. Having more learners than patients could be actually a bad thing. You will have to be aggressive and show the educational value of an observation medicine rotation to your department and to the institution to get some funding for release time to do this properly. Remember, the pot is only so big, and if you want to fund your cause, it'll take some lobbying. When you go home and set up your rotation, you should set the goals that you can reasonably hope to achieve given the limitations of your setup. Setting expectations is key. It is important to honestly communicate with the resident prior to starting the rotation what is expected of them and what they are supposed to learn. Learners can be a critical lot, and they will trash the rotation if they do not perceive value. More and more residents are now familiar with the concept of observation units and understand that they may be required to work in a unit upon graduation. It is relatively easy to create a pre and post rotation evaluation of a resident's knowledge base and attitude towards observation medicine. The next 2 slides are an example of what we use at VCU. We also encourage free form comments as well and use the feedback to tweak our rotation to meet learners' needs.
Hi, this is Aini, and during this section, I will be speaking about incorporating observation medicine education into your emergency medicine curriculum. During this section, I will discuss the importance of observation medicine education towards the training of future emergency medicine physicians. I will review specifics of how to incorporate observation medicine into resident curriculum, the sustainability and reiteration of observation medicine in everyday emergency medicine practice, as well as observation medicine as the extension to the classic house of emergency medicine. Why is this important? while almost half of hospitals have an observation unit. Of those, more than half are emergency medicine run. These percentages are just growing over time. Therefore, this is evolving to make observation medicine a critical competency for future emergency medicine physicians. Let me take a moment for a deeper dive into why this is important. Over the recent years, the practice of emergency medicine has been largely measured by the timeliness of care. We have about 6 golden hours to make a disposition decision. Traditionally, this decision has been sick versus not sick, or admission versus discharge. Though we all know not all patients fall neatly into these boxes. Sometimes we need more time. Patients need to be observed to declare themselves. They need that additional 1 to 2 tests or intervention or consultation. Alas, the tincture of time unit. With this additional time, we can apply an evidence-based practice model for patients presenting with, as an example, heart failure, atrial fibrillation, TIA, PE, so forth and so on. This in turn allows for safer transitions to home for our patients. By being a short-stay observation unit where testing is prioritized and reassessments are frequent, we create value to both the patients we treat and the system as a whole. Opportunities for observation medicine education largely revolve around being superimposed on traditional EM residency curriculum, specifically resident conference, resident rotations, and self-study opportunities as a start. At our shop and many others, observation medicine didactics are standing and built into the annual resident conference schedule. We also dedicate an annual ground rounds to observation medicine and invite national leaders to speak. Our conferences are inclusive, representing all of our clinical environments and inclusive of APPs and faculty from all our divisions, in addition to our residents and students. Therefore, not uncommonly, observation cases are presented and discussed, sometimes by our APPs. There is discussion around dispositions of classic ED cases, with discussion around why versus why not observation, or what is the observation plan for a specific diagnosis. We use flipped classroom activities and even have created a serious game in observation medicine. One of our CDU leaders is also sim trained, so we'll do sessions for residents or an in situ sim for observation staff. For resident rotations, a longitudinal plan is optimal. We have a 2-week-long intern rotation with self-study materials provided to each intern prior to start of their rotation. They are given our clinical decision unit handbook with general guidelines and all general pathways, as well as all relevant publications for their review prior to the start of shift. They work alongside our APPs and present and review cases directly with the EM attending working in the observation unit that day. We also have a senior year elective and moonlighting opportunities for our seniors. Educationally interested seniors have helped with new pathway development and implementation. Administratively interested seniors do an admin elective with many observation medicine components, including the ABCs of building an observation unit and knowledge of key benchmarks and key metrics. Sustainability relies on persistence of observation medicine in everyday emergency medicine practice. Our rotators learn what is and is not appropriate for our observation unit. We have a dedicated faculty group that work the majority of their shifts in our clinical decision unit, but importantly also work clinically in the ED. And by having presence there, it leads to just-in-time learning opportunities in regards to observation medicine. Namely, if a patient in the ED is going to the observation unit, the importance of creating a plan and thinking about milestones for safe transition to home versus milestones towards disposition to full admission are important things to consider. Our focus is GME, but there are opportunities for a variety of learners in the observation unit, including medical students, EPP learners, and fellows as well. In conclusion, observation medicine is an extension of emergency medicine. The patients in the observation unit are our bread and butter. It is the emergency medicine safety net. It is emergency medicine's tincture of time to allow for evidence-based practice model for better transitions of care for our patients to home or hospital. Therefore, observation medicine education is vital to wholesome emergency medicine education and practice. Thank you very much.
Hi, I'm Dr. Chrisbaugh. I am an emergency physician and the Vice Chair of Clinical Affairs at Brigham and Women's Hospital in Boston. For my section of this presentation, I'm going to be discussing faculty education with regards to our observation medicine educational curriculum. I think the faculty is a group that needs to be thought about differently than the resident group at your site. As we've previously discussed, observation medicine is typically overlooked as a discrete body of knowledge that needs to be integrated into an educational curriculum. So that affects not only the residents in your program, but also the faculty. The faculty are typically tasked with educating those residents, and if the faculty are uncomfortable with the knowledge of observation medicine, then it seems like it may be unfair to ask them to lead the educational components of the residency without supporting them. And so as leaders at your sites interested in supporting observation medicine, there is a need to support the faculty in addition to the residents. And so how does this actually accomplished? Well, it takes leadership to be engaged and supportive of the faculty. The chair or chief of the group needs to recognize the importance of observation medicine topics. And that's because there will be airtime that is very valuable at faculty meetings and educational sessions that will need to be set aside for observation medicine principles and topics. And that, as I mentioned, that is valuable time, and there are lots of competing interests. And so having leadership recognize the importance and make a commitment to setting aside that time is going to be very important. In addition, the other resources that you're going to need from your department that require the leadership to be backing you will include data analytics. And there are many operations projects typically ongoing at any given time that are typically saturating the data analytics capacity of an emergency department. Having data for observation medicine is something that is really essential, and that's because you need to be able to tell people how they're doing with regards to observation care. You need to be able to tell them what the conversion to inpatient rate is, what the length of stay is, what the different types of conditions that are managed in the observation unit and how those may be changing over time. That's going to need to be put into dashboards or reports and then shared back to faculty who are ultimately responsible for choosing the patients who will go to the observation unit. And then lastly, there really needs to be recognition of a leadership role for the observation services, and that's typically a physician, but at a lot of places that have APP-run observation units, a lead from that group as well should be recognized. And then, of course, nursing as well needs to have a strong voice in a leadership group. And so when I say leadership, typically that means giving some degree of protected time or a stipend to recognize the administrative work that goes on to lead an observation unit, and that requires the chief or chair to value that time and recognize it in that way. So I mentioned the leadership group that would be in charge of the observation unit. That group needs to collaboratively develop what I would call an observation unit manual or a policy. This would be kind of principles or philosophy of use of the observation unit. It would detail the staffing of the unit, the transitions of care and how shifts might overlap to allow for pass off, the resources available in the observation unit. It may explicitly detail the types of exclusions, the types of patients or scenarios that will not be cared for in the observation unit. This is a resource that would be very helpful to faculty to help them understand kind of the rules of engagement of the observation unit. It also could be very helpful in onboarding or orienting new faculty members joining the group, especially those who do not have experience with observation medicine, which is still a pretty common occurrence. So you are going to have a group of protocols, existing protocols, and there will be a constant need to either update or upgrade existing protocols because the evidence behind those protocols is always changing. Usually at least once a year, it's worth taking a look at the protocol to make sure nothing significant has changed. It could be that you take a look and there's nothing that's changed and you move on. But oftentimes it could be improved. And then you also look for opportunities to create new protocols, protocols that you don't have currently that you might have heard other institutions using, or perhaps a new paper has come out with new evidence that a risk score for a particular condition is well validated, and now we can identify with evidence-based tools which patients will do well in the observation setting. And so you'll need to be working on protocols all the time. I found one way to engage faculty in these protocols is to try and match a faculty's clinical interests, and that could be something they enjoy speaking about, they've given talks about it, or they enjoy teaching the residents on a particular topic, or it could be an area of research interest. A particular faculty member has a grant or has written several papers on a particular topic. That's a great entryway into pulling them into helping as a opinion leader or content expert into helping either update or create a new protocol that aligns with their interest. So we also talked a bit about follow-up, and before I was mentioning more kind of data or numbers, I think there's also a lot to be said about telling a vignette or a story about a patient presentation. And one of the most valuable things that an observation unit provides is the opportunity for a save, right? So this is like a more subtle presentation that becomes more obvious over time that could have easily have been discharged home if the observation unit was not available as a disposition option. And now with the tincture of time, the patient's presentation becomes more clear. They are urgently managed, go to the operating room or have an intervention and have a great outcome. I think it's important to feed these stories back to the physicians and APPs and nurses who work in the observation unit and select patients for care in the observation unit. Engaging faculty in these stories, in addition to the residents, is an important element. As I mentioned before, it's typically the faculty who hold ultimate responsibility for the patient disposition, and that includes the disposition to the observation unit. You know, a resident might suggest the observation unit, but ultimately the faculty member who's seeing that patient needs to agree with that recommendation and ultimately own and be responsible for that. And so one way to engage faculty around kind of whether they're making reasonable decisions around who should go to observation is to track the relative percentage of disposition for each faculty member. And so you can think about it maybe in 3, or depending on where you work, 4 buckets of admit to inpatient, assigned ED observation, discharge home, and if you're at a site that transfers a lot of patients, maybe the 4th bucket is transfer. And what you should see is, you know, somewhere between 5 and 10% of your disposition should be to your ED observation unit. And if you notice some faculty members who are significantly outside of that range, it could be an opportunity for feedback and for them to reconsider some of the cases in the margin. And so, for example, if you have a faculty member who's using ED observation for 15 or 20% of their patients, and they're not discharging to home as much, that doctor may be overusing ED observation for patients who would be better served just being sent home. On the other end of the spectrum, you could have a doctor who is admitting to inpatient quite a few patients and is very rarely using ED observation. That's maybe a physician you might want to, who might be reluctant to use observation. They don't understand it or feel comfortable with it. That would these data would help highlight who those doctors are and help inform some change in their practice. Another aspect of faculty education that you could curate as an observation medicine leader is to distribute or share at some interval, latest observation unit or observation medicine papers with your faculty group. You know, it's unlikely that your faculty group who are not engaged in the leadership of observation medicine are kind of saving or reading thoroughly articles related to observation care. And so what you should be doing, you should be keeping up to date with the literature, and then setting aside papers that you think the rest of your faculty group would really benefit from seeing, and not every week or every month, but maybe once or twice a year, you could share PDFs or links to those papers with your faculty group, and maybe give a little breakdown summary of the kind of headline from each paper. And then for those who are interested, they could read the full paper. That's a way of kind of keeping your faculty up to date with observation medicine evidence by doing a lot of the heavy lifting around kind of finding and summarizing and providing these papers. It will help you become even more of a content expert on this topic, which you are interested in, but then it's also going to help lift up the rest of your faculty group. So lastly, just a summary slide, a few points that we've discussed is that you typically will find gaps in faculty education related to observation medicine. And so it's important to support faculty who will be teaching residents and APPs with information and resources that are related to observation medicine. You often will have to supply those to the faculty. It's very important for your chief or chair to be supportive of observation medicine and give resources that are dedicated to a curriculum and to education. We talked about engaging faculty's specific content interests into helping to update and keep up-to-date existing protocols and create new ones. We talked about a feedback mechanism so that faculty can better understand how to use an observation unit to its full potential. And then having the literature up to date for your faculty and making sure that you're sharing that. So that's all I had. We're going to finish up with the next speaker. And thank you so much for your attention today. Very grateful.